The prescription of psychotropic medication for people with intellectual disability and indeed autistic people has had its share of controversies in recent years. This chapter in the Health Education England document is an examination of some of the key issues in this area and ends by offering a number of practical and pragmatic tips for practicing clinicians. There are three broad issues being addressed. The first part is the challenges which are associated with treating mental health problems in these groups. Secondly, some guidance on good prescribing practice and guidelines. And finally, how to self-audit prescribing practice. It could either be self-audit or it could be part of the governance structure of organizations. And I'm only giving you the brief headline. So the challenge of prescribing in challenging behavior. The main problem is challenging behavior is a descriptive term, and it is often used by both professionals and non-professionals as if it were a diagnostic term. It is a social construct. It covers a wide and disparate range of behaviors, from self-injury to aggression towards others, to self-neglect, to the risk of exploitation. Suffice to say that in mental health settings, most mental health conditions will present with one form of challenging behavior or the other, while all challenging behavior may not necessarily be due to an underlying mental health condition. So if you look at it from that perspective, you identify three categories of patients who come into contact with primary or secondary care services. There are those with challenging behavior clearly associated with a mental illness. There is challenging behavior not associated with any mental illness at all. So those are the two clear-cut categories. And then there is this very large and rather fussy category where you have challenging behavior and some psychiatric symptoms, but they do not quite fulfill the full and clear criteria for a mental illness. And it is important to recognize which of these three groups patients fall under. And we address in the chapter, we address each of those groups in turn. So the challenging behavior plus a clear mental illness group, the main source of evidence-based information is the NICE guidelines on intellectual disability and challenging behavior, a few years old now. And the underlying message is you actively and fully treat the mental illness comorbidity. There is a judgment to be made on the doses that are used. Conventional advice is to start low and go slow, but you should balance that against the risk that in starting too low and going too slow, you end up under-treating the mental illness, thereby worsening the long-term prognosis. And when it comes to the other category, challenging behavior, clearly no mental illness and none of the underlying factors as well. There is a role for psychotropic medication if it is fulfilling those three bullet points that are highlighted by the red circle. So their psychological interventions are being offered, and the treatment of coexisting conditions haven't led to any improvement. And crucially, the risk to the person or others is severe. And then you have a short-term indication for the use of psychotropic medication. It is worth noting that while people say that there is no evidence for the effectiveness of psychotropic medication, the NICE guidelines looked at that in some detail. And what is clear is the standard of evidence is quite poor or just about poor. But the standard of evidence for pharmacotherapy rates almost at the same level as the standard of evidence for psychological interventions. So there's scope for improvement, but that scope for improvement is across the board for all interventions in challenging behavior. And then we come to that third fuzzy category, the challenging behavior, plus we are not quite sure if there is a mental illness category. And once again, the NICE guidelines for mental health conditions address this issue in some detail. And I've highlighted two key points there. There are categories for atypical presentations in all diagnostic systems. So you needn't fulfill the criteria for every single one of the psychotic illnesses or the affective disorders, but there can be atypical presentations. What is really important is the prescriber gives a narrative account of the symptoms and symptom clusters that is forming the basis for prescribing. So, and prescription should be based on that narrative account, whether it is syndromal as in a full-fledged diagnosis, or whether you are addressing specific symptom clusters. And the Frith guidelines, treatment guidelines for people with intellectual disability, which is probably one of the most widely read books in this area, proposes, if you do not have clear diagnostic categories, they propose 5 symptom clusters, and those are listed on the slide. The cognitive perceptual, which is in everyday practice hearing voices in my head and not quite sure whether they are hallucinations or not, affective dysregulation, anxiety. So those are the 3 mental health, psychopathology related symptoms. And then there are 4 or 5 subtypes of aggression and 4 or 5 subtypes of self-injury that are described. And the Frith guidelines actually provides you with flow charts on how to approach various psychotropic drugs for those clusters. I will end with how to audit, how to either self-audit or audit prescribing practice through governance structures within organizations. And I will end with those 7 key messages of how to audit. The first message, of course, is the responsibility is the prescribers. The person who prescribes psychotropic has an overall responsibility to ensure monitoring. The second is when you're writing indication, just writing challenging behavior may not be precise enough as a recorded indication. You need to record all diagnosis systematically and the narrative that underpins it. And the sources that I showed you will give you a list of all the diagnostic planes that need to be recorded. Crucially, you need to record target symptoms or syndromes and have provisional timeframes for evaluation. And that needs to be communicated to all concerned. So the service user, if that is feasible, family members or carers when they are available, and other members of the treating team. In a number of cases, prescribing of psychotropics will be off-label. That by itself is not inappropriate, that is not unlawful, and it is not necessarily unethical either. Off-label prescribing happens in a range of medical settings, from vulnerable, the most vulnerable like neonates and pediatrics, to serious medical conditions like delirium or malignancies. But off-label prescribing, if it is not done properly and following the guidelines that are mentioned, it could be very inappropriate. And finally, you need a standardized outcome measure that can be recorded quickly and implemented widely. And the chapter and the NICE guidance mentions things like the global impression, the clinical global impression scales, things that can be rated by treating clinicians within a very, very short time frame within a consultation. And I'll end on that note. So the aim is to prescribe rationally. And when you do that, reducing and stopping inappropriate psychotropic medication becomes a part of that process. So reducing and stopping medication is not an end by itself, but a natural outcome of rational prescribing practice. Those are my contact details. Please feel free to get in touch. And I'm grateful for your attention.